Good afternoon.
Good afternoon, Doc.
Are you sharing accounts? Parang konti lang yung online. Okay. Yes. Thank you, Pao. Mm-mm. Okay, so it's 5:30. We'll have two topics for this afternoon. Can you hear me?
Yes, Doc.
Hello? Feel free lang to interrupt me, ha? Tell me kung choppy. We'll discuss two topics this afternoon. Short lang naman. So I think we'll finish in a little over an hour. Okay, start na tayo. Okay, sige. First, we'll talk about increased intracranial pressure. So increased intracranial pressure is not a disease etiologies. Identifying and treating elevated intracranial pressure is imperative in the proper treatment of patients in neurocritical care settings and is essential in improving long-term outcomes. Thus, increased ICP is a neurologic emergency that requires prompt recognition and control to avert serious neurologic sequelae and death. So for this afternoon's lecture, our objectives will include, number one, identify normal from increased ICP, discuss the pathophysiology, briefly lang, no? Briefly discuss the pathophysiology of increased ICP, identify the causes of increased ICP in children, explain the symptomatology, and discuss the different management forms of increased ICP. Okay. So intracranial pressure is the sum of the individual pressures exerted by the brain, blood, and CSF. Any change in the volume of one of the normal intracranial components must occur at the expense of the other. So this is known as the Monro-Kelly hypothesis. In physiologic states, ICP remains constant despite a variety of transient perturbations. So the normal intracranial pressure ranges from 0 to 1 millimeters water. Take note that 1 millimeter mercury is equal to 13.6 millimeters water. Typographical error to, millimeters water. So in infants, the normal intracranial pressure is 1.5 to 6 millimeters mercury. In older children, 3 to 7.5 millimeters mercury. And we say that the ICP is increased if the pressure is more than 20 millimeters mercury. Okay, so in neonates and preterms, the cerebral blood flow is at 40 ml per 100 gram per minute with a brain mass of 400 grams. In children, the cerebral blood flow is at 100 ml per 100 grams of brain tissue per minute with a brain mass of 1,300 to 1,400 grams. So ganyan kabigat yung brain ng children. The direct result of increased or elevated intracranial pressure is reduced cerebral perfusion pressure. which can result in cerebral ischemia, eventually edema, eventually herniation, potentially leading to disability and increased rates of mortality. So CPP, or cerebral perfusion pressure, minus ICP. So CPP, cerebral perfusion pressure, is considered an indirect measure of cerebral blood flow and is always inversely proportional to intracranial pressure. So with increased ICP, there is decreased cerebral perfusion pressure. Now, other than the volume of blood in the cranium, the ICP is also determined, of course, by the rate of CSF production and rate of CSF reabsorption. So again, brain, blood, CSF. Now, what is the CSF volume? In infants, it is 4 ml per kilo. In children, it's 3 ml per kilo, and in adults, 1.5 to 2 ml per kilo. So, for example, in a 50 kilogram adult, so 2 ml, 100 ml CSF, half a glass full. And the formation rate is as follows. It's 0.4 ml per minute. Per minute yan ha, so medyo madami. Or 20 ml per hour or 500 ml per day. So we produce about half a liter of CSF per day. Imaginein mo kung hindi yan ma-absorb due to a block in its drainage. So in infants, we already mentioned this in our past session. In infants, because the skull accommodates, increased ICP will manifest as large head, bulging fontanelle, gaping sutures, positive McEwen sign, impaired up gaze, shrill cry, and failure to thrive. So we are very cautious in applying the concepts of intracranial hypertension derived from experience with adults. So in older children, increased ICP is more likely to present with diplopia, headache, mental changes, nausea and vomiting, and papil edema. So papil edema is an objective sign of increased ICP on your exam, or PE. Now, what about late manifestations of increased ICP? So late stage, sobrang taas na ng pressure na hindi na ma-manage. Okay. So there is difficult to fix dilated pupils, posturing. So kung may posturing, mga late manifestations nito, decerebrate or decorticate posturing, hypertension, irregular respiration, bradycardia, ito yung Cushing's triad, although not commonly seen in children kasi nag-accommodate yung skull. These are late signs of late manifestations of increased ICP. Loss of reflexes, the brainstem reflexes, so loss of corneal reflexes at the level of the midbrain, loss of the gag reflex, midbrain and pons, yung corneal, and then gag, medulla. So kung hanggang doon na yung ipit, you lose this brain stem reflexes. Causes of increased intracranial pressure or intracranial hypertension. So focal mass effect or mass effect, when there is a focal lesion such as a brain tumor, infarction with edema, hematoma, abscess. For space-occupying lesions, yung pinakamatandang neurologist sa UST, sabi niya, Chang! Tandaan niyo yung Chang! Si Tatang. So, cyst, hematoma, abscess, neoplasm, granuloma. So, Chang daw. And of course, infarction, focal infarction with edema. So, Changge, kasi may eye na. And for generalized cerebral edema or brain swelling, you will see this in diffuse ischemic anoxic states, no, post-arrest, no, shock. Also in hypertensive encephalopathy, in patients with pseudotumor cerebri, carbon dioxide is a potent cerebral vasodilator. Also in Reye's syndrome. We also see intracranial hypertension when there is increase in venous pressure. So, di ba, yung CSF circulation natin, yung absorption niya, papuntang arachnoid granulations, which indent the superior sagittal sinus. So, if my venous sinus thrombosis anywhere from the superior sagittal sinus down to the jugulars, pwede kang may increase in venous pressure, increase in intracranial pressure. Also in heart failure and obstruction of superior mediastinal and jugular veins when you have tumors, no? Or any lesion obstructing this major thoracic. You will also see increased intracranial pressure with obstruction of CSF flow and its absorption, such as in hydrocephalus, meningitis, carcinomatosis, granulomatosis. So increased CSF volume, such as in meningitis, kasi merong inflammation, also in subarachnoid hemorrhage. So additional volume sa subarachnoid space, mataas ang pressure. CSF overproduction in choroid plexus tumor, no? Choroid papillomas. And then other causes, there are cases na hindi alam yung cause, no? So idiopathic intracranial hypertension. So we'll talk about cerebral edema. This is due to an increase in the brain's volume due to an accumulation of excess fluid, either intra or extracellularly. So this could be generalized or localized cerebral edema. And we have three major types of cerebral edema: the vasogenic, cytotoxic, and interstitial or transependymal edema. Okay, so vasogenic edema, this occurs when there's failure of tight junctions and astrocyte processes which normally maintain an adequate blood-brain barrier. So in patients with brain tumor, trauma, hemorrhage, so there is increased capillary permeability. So vasogenic edema is seen primarily in the white matter. Okay. The edema has good response to corticosteroids, and diuretics have no effect on this, but medyo helpful lang yung diuretics a little bit, no, by reducing the normal brain volume. Pero drug of choice is corticosteroids. That's why for neoplasms you give steroids, no? Yan. So this is focal cerebral edema. So yung first, is this CT or MRI? This is intraparenchymal bleed, no? Left frontal lobe. So acute bleed. So acute hemorrhage. Puti ang dugo. So this is CT scan, no? Mahirap makita ang dugo sa MRI. So vasogenic edema. Pwede ito hypertensive bleed or tumoral bleed or traumatic bleed. So ito CT scan kasi kitang-kita mo yung skull, puti. So ang puti sa CT scan, again, blood, bone, calcified structures, contrast. Okay, puti. So the second image, this is T2, di ba, MRI. Ang nakikita mong puti, hindi siya bone. That's fat, no? Fat. Bakit may fat? Sa diplo, meron tayo fat. So this is T2. This is T2 flare. T2 flare. So makikita mo rin yung ito, fat, subcutaneous fat, no? Ng scalp. Sa megalia aponeurotica, you have a loose areolar tissue. So dalawang puti. May stripe ka dyan. Puti. Ito, edema. So bilateral occipital edema. You usually see this in patients with hypertensive encephalopathy. Okay? So patients having hypertensive urgency or emergency, no? Meron silang bilateral para ito occipital edema. Ito yung appearance on MRI. This is T2 flare. Okay. Edema, the blood-brain barrier remains intact, unlike dependent motion pumps. So as a result, the cellular retention of sodium and water intracellularly so there is swelling of cellular elements. So astrocytes get involved. Since they are also found in the gray matter, yung astrocytes hindi lang nasa white. So both gray and white matter are involved. So upon neuroimaging, yung kanina, di ba, vasogenic edema, mainly white matter. With cytotoxic edema, both gray and white matter. So on neuroimaging, indistinct na nakikita. Usual causes are hypoxia, ischemia, infection. So mas common talaga hypoxia, ischemia, mga post-stroke patients or post-HIE patients. This time, steroids have no effect. Kaya we don't give steroids for stroke patients or post-stroke patients. And osmotic diuretics may relieve ICP by reducing blood volume. You will also see cytotoxic edema in intoxications, no? So this is the appearance of cytotoxic edema. If you have stroke, so involved man yan entirely. White matter, gray matter, neurons, astrocytes, microglia, etc. So lahat sila nagsuswell. So kita mo siya parang diffuse yung swelling. I mean, it involves the entire cellular elements. No, unlike in vasogenic edema na meron ka pang nakikita separate na naiipit na, no? And you have neck stiffness if you have cerebellar tonsillar herniation. So matigas yung lieg. Kala mo nagme-meningitis na nag-herniate na pala. So these are the herniation syndromes. We'll refer to this caricature from time to time. First, we'll discuss cingulate or subfalcine herniation. Ito yung cingulate gyrus, no? So subfalcine kasi below the falx cerebri. So other literatures mention subfalcial herniation. So this is unilateral shift, midline shift, no? Unilateral midline shift. And there are no specific sets of or signs and symptoms, sets of assessment findings on neuroexam usually, no? This is detected by neuroimaging. Minsan nga parang ano lang siya, incidental finding. Gising yung pasyente mo, nagsa-subfalcine herniation na pala. So this is detected by imaging, cranial CT scan, MRI, but this is an indication for brain decompression. And this is also an indication of poor intracranial compliance and may lead to further injury related to localized compromise in blood flow and tissue distortion. So ano yung andito sa harap, yung dumadaan dito sa harap na major blood vessels? It's the anterior cerebral artery. So if this is untreated, pwedeng mag-ischemia, no, from compression of your anterior cerebral artery. So usually midline shift happens or occurs when there is a focal space-occupying lesion. So may shift to the contralateral side, pumapasok yung cingulate gyrus mo below the stiff falx cerebri. Next is uncal herniation or what we call the transtentorial herniation. Ito yung madalas nating makita clinically, di ba? You will see unilateral dilated, slow to reactive pupils, yung anisocoria, di ba? So, nagpapanik na tayo pag the patient is already anisocoric kasi pwede na siyang mag-progress to bilateral, fixed or dilated pupils if untreated. So, bakit uncal herniation ang tawag? Kasi ungkus yung bumababa, no? Pumapasok sa tentorium cerebelli. Okay, so ito yon. My red circle. You will see weakness of EOMs. Kasi andito naman midbrain, di ba? Midbrain and pons. Diyan lumalabas yung ating mga cranial nerves for our extraocular muscles. There is decreasing level of consciousness which will eventually progress to coma kasi may ipit na yung ARAS mo, ascending reticular activating system. Pag hindi ka mag-manage promptly, you will see changes in vital signs and eventually cardiopulmonary arrest kasi andito na yung respiratory centers. Andito yung respiratory centers mo. So the patient also will manifest with decerebrate posturing, flaccidity. So again, yung subfalcial or subfalcine herniation usually detected by neuroimaging, ito clinical, no? Kaya ang malaki yung gamit ng iyong pen light. Okay, so this will just show you the Kernohan sign. This is the uncus, no? If you have a lesion here, for example, a subdural hematoma, kung di siya ma-evacuate, you'll have uncal herniation. Maiipit yung contralateral midbrain mo sa contralateral tentorium cerebelli. So this is actually, yung Kernohan sign is a false localizing sign. Why? So andito yung lesion mo, for example, sa left, yung weakness mo, ini-expect mo contralateral sa right kasi di ba yung cortical, your cerebral hemisphere, pag andito yung lesion, opposite or contralateral limb weakness. Pero meron kang ipsilateral limb weakness. This is a false localizing sign kasi pumasok na dito yung uncus na ipit yung contralateral midbrain sa tentorial notch on the opposite side. Yung very stiff kasi di ba dural fold din ito. So you will have an ipsilateral weakness then. So meron ka ng contralateral limb weakness, meron ka pang ipsilateral limb weakness. So this is a false localizing sign. By the way, yung decussation mo kasi is lower brainstem pa man. So bilaterally, naiipit yung cortical spinal tract mo. So dalawa yung weakness mo. Both lower limbs are weak. So that, no, nalilito minsan yung mga doctors ma-localize because of this Kernohan sign. Next is tonsillar herniation. So this is also known as transmagnal or transforaminal herniation. So this is the foramen magnum. Usually it's the cerebellar tonsils, no, that goes down. So tonsillar herniation, ito yung magmamanifest ng nuchal rigidity. So there's neck pain and stiffness, also flaccidity. Emergency din ito ha, kasi pag naipit din yung iyong aras, your patient will go into coma. And also, you will see changes in vital signs, no? Pulse, respiration, BP. Now, central herniation. Central herniation naman, this is parang dalawang uncal herniation, bilateral. So, yung buong center ng brain bababa through the tentorium cerebelli. So, this is central tentorial herniation. The pupils are constricted, initially reactive to light, and eventually magiging fixed dilated silang dalawa. So, parang walang anisocoria, no? Kasi dalawa sabay. Pero, initially constricted muna, and then eventually magiging fixed dilated. Ito super emergency ito. And it will also initially present with, it might present with vertical gaze palsy initially, progressing to fixation of both eyeballs, no, frozen eyeballs. There is confusion, progressive decrease in consciousness, no? From weakness to paralysis contralateral to the lesion, but eventually the patient will have decortication, decerebration, and unstable vital signs, and eventually CP arrest. Okay, so for diffuse lesions or generalized cerebral edema, you will see central herniation. Yung uncal herniation, pag mga focal kadalasan, no? Focal lesions. Also for transmagnal or tonsillar herniation, pag medyo diffuse din yung lesion, bilateral. Although pwedeng unilateral tonsillar herniation. But for central herniation, you will see this in diffuse cerebral edema. Okay, so the treatment of intracranial hypertension should be directed to the underlying cause. So of course, you need a good history, physical examination, complete neurological examination. Always check for the level of consciousness and then uncover possible etiology, confirm it with neurodiagnostics, no, or do metabolic testing. And the evaluation of the child with increased ICP also includes stabilization, no? So the goals in the management include, number one, of course, is normalizing the intracranial pressure, optimizing the cerebral blood flow and cerebral perfusion pressure, prevent second insults that exacerbate secondary injury. For example, yung nakikink yung blood vessels mo, eventually the patient will have ischemia, which will further exacerbate cerebral edema, and avoid complications associated with different treatment modalities. So the general management of increased intracranial pressure includes, number one, maintaining the head at neutral midline position with 30 to 45 degrees elevation. This is to facilitate venous drainage through the jugular veins. Number two, minimize activities that can increase intracranial pressure, such as suctioning, gagging the patient. No? Number three, manage hyperthermia as it increases the metabolic needs of the brain. So manage the fever. Maintain fluid balance, monitor electrolytes. Kasi pag halimbawa hyponatremic, may intracellular swelling din, no? Pag hyponatremic yung pasyente. Do hyperventilation to maintain carbon dioxide, PCO2 at 25 to 35 millimeters mercury. Kasi pag sobrang taas niyan, hypercarbic yung pasyente, all the more na magsicerebral edema because of vasodilatation. So you target PCO2 of 25 to 35 to ensure vasoconstriction. Pero hindi naman sobrang baba, like less than 20. Otherwise, mag-ischemia din kung sobrang vasoconstricted yung pasyente mo. Medical management will include, number one, anticonvulsants. So symptomatic na to. So you give anticonvulsants if the patient is seizing. Kasi when you're seizing, increased BP, increased ICP, no? Control of systemic hypertension, so self-explanatory. And then you manage cerebral edema with the use of diuretics such as mannitol, acetazolamide, furosemide, or you give steroids or hypertonic saline. Or you induce coma to reduce the cerebral metabolic requirement for oxygen. And you monitor the intracranial pressure. So the most popular medication that we use to decrease intracranial pressure is vitamin M, sabi ni the late Dr. Asoy, vitamin M. So mannitol, 20% solution, given at a dose of 0.25 to 1 gram per kilo or 2.5 to 5 ml per kilo, infused IV bolus, no, hindi IV drip. The duration of effect is up to 6 hours. So anong gamit ng mannitol? This increases gradient across the blood-brain barrier, which result to rapid reduction of intracranial pressure. Now, since this is a plasma expander, there is transient expansion of intravascular volume. Brisk osmotic diuresis results. No, that's why you do BP monitoring prior to administration of the medication. Kasi your patient might have hypovolemia, hypotension, no, because of the diuresis. And of course, by the way, remind ko lang kayo, if you give mannitol, no, please check that your patient is voiding, ha? Kasi minsan kadalasan comatose yung pasyente. Or kahit stuporous lang, tas biglang nag-restless, di pala nakakaihi. So, ang laki-laki ng your urinary bladder, punong-puno. Sobrang sakit niyan. So, kung comatose yung pasyente mo or stuporous, you insert Foley catheter, ha? Urinary catheter. Baka mag-rupture yung bladder mo kung hindi pala umiihi yung pasyente. Ha? Kasi down yung sensorium, tas mannitol ka ng mannitol, maya-maya nag-acute abdomen na kasi nag-rupture yung bladder mo. So, the excretion of mannitol is by the kidneys. So, when used in very large doses, this may cause renal failure. So again, adverse effects, hypovolemia, hypotension, and renal failure. Minsan, nakakalimutan tanggalin yung mannitol. So you can give mannitol every 4 hours, 6 hours, 8 hours. In 3 to 5 days lang. Minsan nakakalimutan i-monitor yung pasyente, naging pasas na siya, naging racist, na-dehydrate, no? Or sobrang taas na ng sodium, or sobrang hypokalemic na because of the diuresis. So you monitor your patients, don't give mannitol longer than 5 days, ha? And you taper. Vitamin M yung tawag yan, Dr. Asoy. Next is hypertonic saline. This is a more recent treatment for increased ICP. So we use 3%. Actually, ano yan 3 to 23%. Pero what is available is 3% hypertonic saline solution. And same with mannitol, the duration of effect is up to 6 hours. It also increases gradient across the blood-brain barrier. That's why this induces rapid reduction of ICP. But adverse effects include hyperosmolar central pontine myelolysis, congestive heart failure, subdural hematoma, and coagulopathy. So mas marami actually babantayan with HTS. That's why minsan isang bigayan lang tayo at 2 ml per kilo bolus kasi nga sobrang taas ng sodium. 'Di ba? Our NSS, normal saline solution, is just 0.9%, 'di ba? HTS is 3%. So medyo marami. Corticosteroids, so this is for vasogenic edema. You give dexamethasone at 0.1 to 0.2 milligrams per kilo every 6 hours. Onset of action is 12 to 24 hours. So cerebral blood flow is not affected. I mentioned kanina, di ba, hyperventilation, where you maintain PCO2 at 25 to 30, di ba yung normal 25 to 35. Yun yung pinakamabilis yung effect. No? Hyperventilation. So, bag ka lang, mabilisan. Blow off mo yung CO2. So, magdi-decrease yung intracranial pressure. Yun yung pinakamabilis. Next would be mannitol and hypertonic saline. Yung pinakamatagal umepekto is corticosteroid. Diba? So, hindi talaga siya pang emergency. So, 12 to 24 hours pa bago siya umepekto. Another treatment modality is hypothermia, just to decrease cerebral blood flow. Kasi nga, di ba, yung intracranial pressure is determined by the volume of blood, brain, and CSF. So hypothermia will decrease cerebral blood flow, thereby decreasing intracranial pressure. So body temperature is maintained between 27 to 31 degrees Celsius. Next is pentobarbital coma. To reduce cerebral blood flow and to decrease cerebral edema formation, because this lowers the cerebral metabolic requirement for oxygen, the CMRO2. So you put your patient in coma. Those should produce a burst suppression on EEG. So pinapatulog mo siya, pinapatahimik mo yung neurons. So dapat may simultaneous EEG while giving the thiopental. The dose is 5 milligrams per kilo over 10 minutes, and you taper this gradually 48 hours after ICP decreases. And this is ideal for disorders of mitochondrial function such as Reye's syndrome. So for severe diffuse cerebral edema. We also have surgical management for intracranial hypertension. You can insert EVD, external ventricular drainage, both for intracranial monitoring, intracranial pressure monitoring, and for drainage of CSF. So ito yon. I hope nakikita nyo, no? Yung catheter. So the catheter is placed into one of the lateral ventricles via a burr hole. And then the EVD is connected to ng CSF. Meron tayong isa dito, intraparenchymal probe. Accurate din, no? Just like EVD, but of course you cannot drain CSF and you cannot recalibrate this. So, ang gold standard pa rin for intracranial pressure monitoring is EVD. And then ventricular shunting or CSF diversion in patients with non-communicating hydrocephalus or ventriculostomy. Ventriculostomy, pwedeng third ventriculostomy or lateral ventriculostomy. And specific management or hematoma abscess, so evacuation of hematoma, excision of tumor, no, or drainage of abscess. For decompressive craniectomy, we usually request for this in patients with malignant infarct, no, large infarcts. We remove a bone, no, skull bone. You request for craniectomy, tapos makikita mo lolobo ang edematous brain, no? Parang gel. So lifesaver din itong decompressive craniectomy. So in patients with malignant infarct or in patients with cerebellar infarct. Kasi yung posterior fossa sobrang liit. If you have cerebellar infarct, ipit ka agad yung brainstem mo, arrest ka kaagad. So emergency decompressive craniectomy, posterior or suboccipital. Okay. So as I mentioned, brief lang ang topics natin tonight. We'll go to the next topic, the pediatric brain tumors. Okay. Brain tumors are the most common neoplastic diseases in children when the hematologic malignancies are excluded. So they comprise up to 15% of all childhood neoplasms. They are rare during the first year of life. Subsequently, they become equally distributed with a peak of occurrence during the second half of the first decade. So rare during the first year of life. Common adult tumors like meningiomas, pituitary adenomas, acoustic neuromas, and metastatic diseases are rare in children. Gliomas account for at least 75% of all pediatric brain tumors. So glioma. 2/3 occur in the posterior fossa. So ano yung nasa posterior fossa? Brainstem and cerebellum. Overall, whether supra or infratentorial, 2/3 occur in midline structures. So what are the midline structures? Ventricles, the optic pathway, no? Optic chiasm, diencephalon, thalami, brainstem, and cerebellar vermis. So yun yung mga midline structures. So again, 2/3 of pediatric tumors occur in the posterior fossa, 2/3 midline, 75% glioma. So, ano yung effect ng tumors, mass lesions? So there is compression, destruction, extension, invasion with associated edema on its primary location and its neighboring structure. So nagkakaipit siya, no? There is obstruction of CSF outflow leading to hydrocephalus and of course increased ICP. You will see also abnormal neuronal functions such as loss of function, weakness, numbness, blindness, or abnormal discharge like seizures, no? And you will also see endocrine hypo or hyperfunction for endocrine tumors. So hypothalamic pituitary tumors, you will see endocrine dysfunction. Non-localizing manifestations, yung usual na signs of increased ICP. So non-localizing siya, non-specific. Sixth nerve palsy is a false localizing sign. Okay, sixth nerve is abducens. Kasi siya yung may longest intracranial subarachnoid course, kaya madali siyang maipit when there is increased ICP. So kadalasan akala may sixth nerve involvement, pero from increased ICP, naiipit lang yung sixth nerve mo, kaya meron kang lateral rectus palsy. So dalawa na yung alam yung false localizing sign, yung Kernohan sign, tsaka yung sixth nerve palsy. Localizing signs include for the posterior fossa tumors involving the cerebellum, syempre kung vermian or vermis midline, you will have truncal ataxia, no? Ataxic gait. If the cerebellar hemispheres are involved, you have appendicular ataxia. So ipsilateral to the lesion. For those lesions or tumors involving the brainstem, so ano yung dumadaan sa brainstem? Long tracts. What do you mean by long tracts? The corticospinal tract and the spinothalamic tract and the spinocerebellar tracts. Those are long tracts. And then you will have cranial nerve palsies. You will have cerebellar signs if your tumor is located in the brainstem. Doon sila lahat nagkikita-kita, no? Cerebellar fibers, corticospinal tract fibers, spinothalamic tract fibers, and of course, the cranial nerves. Kung present silang tatlo, brainstem talaga yung localization mo. Other localizing signs include for midline tumors, visual field loss. So for chiasma, bitemporal. Chiasmatic tumors, bitemporal hemianopsia. Decreased visual acuity when the optic pathway is involved. Nystagmus for blindness, no? Meron silang mga searching nystagmus. Endocrinopathies, we mentioned this for hypothalamic pituitary tumors, precocious puberty. So localizing siya. Nasa cellar, supracellar area yung tumor mo. For supratentorial areas, mas mabilis na mag-localize. You will have lateralizing long tract signs, long tract and sensory signs, contralateral to the lesion, and you will have seizures if the patient's tumor involved the gray matter. Okay, so diagnosis again is via clinical symptomatology and natural history of the tumor, of the lesion. Neuroimaging studies will confirm the location and type, more or less, no? The type of lesion. Surgical exploration, this is both diagnostic and therapeutic, and of course, pathologic examination will confirm the histologic etiology of the tumor. Let's discuss supratentorial tumors. This is, first is craniopharyngioma. So nakikita nyo ito, cellar, supracellar area. So craniopharyngioma, this is most common in the first 2 decades of life with no sex predilection. Manifestations include increased ICP, visual symptoms, kasi nga cellar, supracellar siya. You will have field cuts, bitemporal hemianopsia, blurring of vision, optic atrophy, and endocrinopathies, such as hypopituitarism, diabetes insipidus. Location is supra or intracellular. It could be cystic or partially solid, and this is best seen with neuroimaging, of course, CT, MRI. Skull X-ray, it will show calcifications with erosion of sella. Yun lang. Pero hindi siya makaka-distinguish if the lesion is cystic or partially solid. So this is the craniopharyngioma. Ito after post-mortem, no? Post-mortem examination. You will see this machine oil appearance of the for cystic lesions, no? Meron siyang machine oil fluid. So the tumor is benign, but because of its difficulty to resect, kita nyo, o gitnang-gitna siya, it behaves like a malignant lesion. And there is risk of spillage of contents for the cystic type. We call it machine oil kasi ang itim-itim. During surgery, creating more problem actually. Kasi nagki-chemical meningitis pag nag-rupture siya or nag-spill. The response to radiation is variable, and post-op treatment is frequently complicated, and this is mostly due to difficulty controlling the diabetes insipidus. Kaya I prefer my patients, no, to be operated on in higher centers in Manila kung craniopharyngioma kasi nga mahirap. And post-op, kailangan talaga ng neurointensive care. Grabe silang umihi, no? Diabetes insipidus, litro. Very difficult to manage post-operatively. Kaya I refer na lang my patients to Manila para meron silang neurointensivist na magha-handle post-operatively. So visual pathway tumors. This is one of the most common neuroglial tumors in midline, so left. By the way, para hindi kayo malito, no, yung ating imaging studies, to your right is the left side of the patient. So para hindi kayo malito, imagine niyo nakahiga yung pasyente, nasa paanan kayo. Okay, so this is a glioma, an optic glioma. The association of optic nerve glioma and neurofibromatosis 1 is well established. So 50% of patients with optic gliomas have NF1, mandating search of our skin lesions, our cutaneous signs found in NF1. So the natural history depends on location, and most are in the anterior pathways, kagaya nito, nasa optic nerve talaga siya. It may be unilateral or bilateral or involve the entire chiasm. So kahit saan sa optic pathway mo, pwede kang magka-optic glioma. Anywhere in your optic pathway. So manifestations, number 1, the most common presenting symptom is of course diminished visual acuity. Then patient may present with unilateral pulsatile proptosis. Nystagmus is if the lesion is chiasmatic, so searching nystagmus, no, hindi nakakakita masyado. Field cuts. Masaya, no, pag ma-elicit mo yung bitemporal hemianopsia. So chiasmatic ka agad yung localization. Pero pwede kang mag-quadrantinopsia, homonymous hemianopsia, etc. So very localizing din if ma-elicit mo yung mga field cuts. Of course, increased ICP kasi ang sela, ang optic chiasm, nasa ilalim lang siya ng sa area ng foramen of Monro, no? Pwede siyang makaipit ng drainage ng CSF mo Or if it extends posteriorly, pwede ring makaipit sa third ventricle mo. So increased ICP. Management is surgical excision, and the response to radiation is also variable. Now we go to thalamic and hypothalamic tumors. So this is found in the region around the third ventricle. Andun naman, di ba yung third ventricle borders niya are thalami and then hypothalamus. So thalamic and hypothalamic tumors vary from benign to highly malignant, so malignant gliomas. Age of onset is less than 20 years, and duration of symptoms prior to diagnosis is less than a year. So, ang area ng tumor mo dito. Okay, third ventricle. Symptoms are non-specific, from confusion, memory loss, obstruction of foramen of Monro, tremors, kasi pwedeng ma-involve yung basal ganglia, dysmetria din, which might confuse you with a cerebellar tumor, pero usually nafa-factor in ang weakness niyan, kaya parang dysmetric, may dysmetria sila. Dystonia because of basal ganglia involvement, chorea, balismus, yung mga movement disorders, dyskinesia, so mga basal ganglia involvement, and also the subthalamus. Diba? Balismus is from subthalamic involvement. Patients will also present with endocrinopathy kasi nga gitna siya. Very difficult to resect because of its location, and the response to radiation is variable also. Ito pasyente namin in UST, no? Isang tingin lang ng training officer namin, hindi pa niya alam yung history, na diagnose niya kaagad yung diencephalic syndrome of Russell. Kaya hindi ko ito makakalimutan, no? Ano lang siya, visual diagnosis. This is diencephalic syndrome of Russell. There is tumor located in the anterior hypothalamus or optic chiasm. This occurs between 18 months and 3 years. The outstanding symptoms include unexplained failure to thrive, inanition, nystagmus, euphoria, hyperalertness, and hyperkinesia. It's either anorexia or voracious appetite. No? Okay. So our patient was ang payat-payat, sobrang lakas kumain, pero ang payat-payat. Hyper-alert siya, hyperkinetic. Management is surgical biopsy is desirable. Surgical biopsy and excision, followed by radiation therapy. Pero because of its location, no, ang daming na-involve. Tsaka mahirap kunin lahat yung tumor cells, no, yung mahirap siyang i-debulk. So, poor outcome. Variable response to radiation therapy. So, prognosis also is poor. Then pineal tumors. We go to pineal tumors. They are more common in Asians than in Caucasians. Germinoma represents 50% of all tumors in this region. But you may also see teratoma, epidermoid, or dermoid. Tumors in the pineal region are common among boys and are more sensitive to radiation than suprasellar germinomas, which are more common in girls. So, suprasellar germinoma, naalala ko itong suprasellar germinoma. Meron akong examinee in one oral boards, no? Kuhang-kuha niya yung location ng lesion, yung localization nasa suprasellar area. Kuhang-kuha niya. Pero she zeroed in on craniopharyngioma. So in short, hindi lang craniopharyngioma yung lesion mo sa suprasellar area. Pwede ka ring magkaroon ng germinoma. So hindi exclusive ang germinoma sa pineal gland. Okay? So konting-konting time na lang, nilid na siya hanggang makuha niya yung germinoma. Pero konting time na lang ng oral board examinee na yun, umiiyak na siya. Kasi kailangan pa niyang i-discuss yung management ng germinoma. So again, hindi exclusive ang germinoma sa pineal gland, no? You also see suprasellar, germinomas, particularly in girls. No? Okay. Pineal tumors are mostly malignant and can spread in all directions. So kung asan yung area ng pineal gland, andun yung tumor location mo, ha? Obvious naman. Symptoms are related to increased ICP and Parinod syndrome. So reading assignment nyo, ano ang Parinod syndrome? Again, this is difficult to resect kasi gitnang-gitna siya, no? With high rate of mortality up to 50%. Response to radiation also variable. So this is, pero parang ibang pasyente siya kasi iba yung hugis ng skull. Okay. Hemispheric tumors. Hemispheres. Cerebral hemispheres. No, hindi cerebellar hemispheres kasi nasa supratentorial tayo. Supratentorial above the tentorium, cerebral hemispheres. So when we say hemispheric tumors, supratentorial, cerebral hemispheres. Majority of these tumors are low-grade astrocytomas. High-grade astrocytoma and glioblastoma. So the lesions are generally diffuse and ill-defined with infiltration of white matter, cortex, and basal ganglia. Patients will manifest with signs and symptoms dependent on the location of the lesion and the presence of increased ICP. So mga persistent focal headache, one-sided headache, no? Kala mo migraine pero persistently on one side. Seizures, kung involved na yung neuron or gray matter. You can have contralateral hemiparesis, contralateral hemisensory loss. You can have filled cuts. So, quadrantinopsia. Okay? Depending on the area involved. So, madaling malocalize kung hemispheric yung tumor mo. So in general, prolonged duration of symptoms before diagnosis is a good prognostic sign. Ibig sabihin, benign lang siya. Sobrang tagal niyang tumubo. Pag mas mabilis, shorter yung duration ng symptom, mas nakakatakot, no? So mas malignant. Biopsy with surgical excision is usually successful. But only the cystic type, cystic cerebral astrocytoma, is complete surgical resection possible. Kasi parang meron siyang capsule kung cystic. Kaya mas madaling i-excise kung cystic cerebral astro rather than the diffuse infiltrative type. Response to radiation, also variable. So yung more malignant, or malignant, ito yung glioblastoma multiforme, GBM. Outcome is uniformly poor despite combination of treatment modalities. The role of chemotherapy in high-grade astrocytoma is questionable, but results are most impressive in children less than 3 years with chemotherapy. Next tumor, choroid plexus papilloma. So, narinig nyo na ito dati, no? Kasi ito yung may CSF overproduction. So, papilloma involving the choroid plexus. Ito yung itsura niya. So, intraventricular siya. Common during early infancy. It may manifest at birth. The duration is rapid kasi nga nag-hydrocephalus ka agad. So, rapid course occurring in weeks. Signs and symptoms are related to hydrocephalus. Pathology, so majority benign, no? And they're usually found in third or lateral ventricles. So I asked you earlier, saan yung choroid plexus, no? So kung saan yung choroid plexus natin, dun mo makikita yung choroid plexus papilloma. Although meron namang mga malignant types, no? Papillocarcinoma, pero rare lang sila. Resectability is good. And radiation is not indicated kasi benign lang naman siya. Now we go to infratentorial tumor. So infratentorial, brainstem, and cerebellum. First is cerebellar astrocytoma. It is more common in older children, 5 to 9 years of age, especially after age 8 years. It has the most favorable prognosis of all the childhood brain tumor. So equal male to female, no? Yung no sex predilection. Ito yung entire cystic astrocytoma, no? Cystic cerebellar astrocytoma. Fluid, ito lang yung tumor, pero ini-excise mo siya lahat. Okay? So duration of symptoms prior to diagnosis, 6 to 12 months. Medyo matagal kasi pag benign. Manifestations, very localizing, no? Ataxia and ipsilateral cerebellar signs plus hydrocephalus. Kasi ipit niya yung foramen magendi and Luschka. Okay? The astrocytoma may be found in the cerebellar hemispheres or midline in the vermis, mostly benign, with good resectability with a 90% cure rate. So the tumor is not influenced by radiation. Actually, you don't do radiation therapy with cystic piloastrocytoma kasi natatanggal naman siya lahat. Ito yung madugo, yung medulloblastoma. Okay? This occurs more frequently in younger children. So younger kesa doon sa may mga cerebellar pilocytic or cystic astrocytoma. This is more common among males. Kasi nga medyo madugo, more malignant. No? Duration of symptoms prior to diagnosis less than 4 months. Mostly confined in the vermis midline. So ataxia is more truncal. Signs and symptoms of increased ICP is common. So this is the lesion, the tumor. This is highly malignant, no? Kaya kawawa pag nadadiagnose mo yung pasyente na may medulloblastoma. So this is highly malignant and tumor cells disseminate throughout the entire neuraxis. This is sagittal. Ito yung tumor. So, nagkakaroon sila ng mga drop metastasis, pumupunta sa spinal cord. We call it drop metastasis. And even outside the CNS, nadadala ng dugo, kung saan-saan. Okay? Resectability is often incomplete. So, combination yan palagi ng tumor debulking, chemotherapy, radiotherapy, no? The tumor naman is very sensitive to radiation. Kaya lang, kasi nga kumakalat siya kung saan-saan, pati labas ng CNS, pabalik-balik. No? Kaya very poor prognosis. Then we go to brainstem glioma. Ito isa pang madugo. No? This is seen in mid-childhood years, so 5 to 7 years. So no sex predilection, and the duration of symptoms prior to diagnosis is as short as 1 month. No? So 1 to 6 months. Mabilis lang din. tingnan mo, yung entire pons niya, lumobo. This is brainstem glioma. So, doon talaga siya sa gitna ng brainstem. Paano mo naman yan mariresect? So, manifestations include multiple cranial nerve palsies, particularly sevens. Kompleto, no? You have long tract signs, cerebellar signs, headache, vomiting, signs of increased ICP, lahat na ng manifestations, no? Ng increased ICP, weakness, numbness, etc. Imbalance. Resectability is poor, no? Hindi rin masyadong magandang response radiation. Paano mo naman mariresect yung yung brainstem? Although we have the brainstem tumors, no, that are pedunculated. Yun, okay lang yun. Nare-resect yun. Pero pag mga diffuse brainstem glioma, poor prognosis. Excuse me. Next is ependymoma. This occurs in the younger age group. No sex preponderance. The duration of symptoms prior to diagnosis is also less than 6 months. Medyo mabilis din. Ependema. So imagine yung saan yung ependema. So patients manifest with neck stiffness, and this is due to intermittent coning of the tumor dito sa foramen magnum, no? And is often mistaken for meningitis. Patients also present with cranial nerve palsies and hydrocephalus. Again, this is difficult to resect with variable response to radiation. So, axial cut, you will see calcifications, no? Around the area of the posterior fossa. Ayan, so na-obstruct na niya yung CSF outflow. And dito siya nagko-cone, no? Intermittent coning, lumalabas from time to time sa foramen magnum. That's why patients present with neck stiffness. Okay, so I think this is my last slide. Tinanggal ko na yung drill kasi nga hindi naman tayo face-to-face. I'll see you tomorrow for the discussion on seizures in childhood. Questions? Yes po. Okay. Sige. Okay. Good luck sa long exam tomorrow in neurology. Sige. No questions? Gabi na. Nagabihan na kamo. No questions? See you tomorrow. Okay. Good luck.
Thank you, Doc.
Bye-bye.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Ano na? Agulyo? Amo nakabutang? Agulyo? Darlene Agulyo. This is our secretary sa Department of Pediatrics. Okay. I'm Dr. Latorre. Sige. Bye-bye. Good night. Di ko napansin. Thank you for mentioning that. Bye-bye.
Bye, Doc.
Mm-mm.
Thank you, Doc.
Thank you then for
Thank you, Doc.
listening.
Thank you, Doc.